I'm Dr. David Johnson, Professor of Medicine and Chief of Gastroenterology at Eastern Virginia Medical School, and I'm just back from the American College of Gastroenterology annual meeting this year held in Philadelphia, and I wanted to put together my top 10. I'm going to present these in two segues, 5 and then 5, not to put in any prioritized order or categorization of one is the best, but nonetheless give you my top 5 because I think they all have clinical applications, some of which are more immediate, and I think I'll give you where I can 1 or 2 teaching points as I thought when I looked at some of the data in the presentations. First is a study that looked at provocative testing, looking at musculoskeletal injuries, endoscopy-related injuries in those that perform endoscopy. That's what we do as gastroenterologists. And I will give a personal perspective that I've had virtually all of these, and I've had the privilege of being in the field for 45 plus years. But I want to put in perspective, we can do more about what potentially you have or what you potentially should avoid. Now, this is a study that looks at musculoskeletal pain. It came from the University of Utah, and they looked at an author-developed questionnaire that they called the Quick Dash, which is Disability Arm, Shoulder, and Hand Questionnaire. They validated it, and then they went and combined with occupational therapists in their department, looking at ways that they could look at strength testing as well as provocative testing. So what did they see? They had 35 endoscopists, and overall 34% reported experiencing pain, and 17% reported numbness in the previous week. 48% had been bothered by pain, 11% by tingling, and 17% experienced interrupted sleep. I think that's an important point to register because when you have fragmented sleep, so many of you have heard me talk before about sleep, but it lowers sensory thresholds, so your next day response to that interrupted sleep heightens any sensory response. Additionally, 17% actually reported limitations in what they could do at work. So physical testing showed reduction in grip strength in approximately half, right and left-sided in both, and abnormal provocative tests was evident in more than 70%. A couple of risk profiles, if you perform 20 or more procedures a week, you are at higher risk. I recognize some of you perform 20 or more in a day, but again, this is something also we see, and particularly the patients doing the physicians doing biliary endoscopy, 20 to 60% had a higher predictive value as well. So what the bottom line here is there's an extremely high prevalence of repetitive use injury. I don't care if you're just starting or you're more senior or mid-career, you need to be aware of this. Kudos to the ACG. They put together in the hands-on session, there were 2 days where they had extended ergonomics evaluations where they had physical therapists with specific training in ergonomics, and it was standing room only as I went by there in each day, and it's something that even more as well, kudos to the ACG. During the meeting, they announced a publication of ergonomics in endoscopy. This book will be available post-meeting on the ACG website. Go to the bookstore. I'll give you a link on that as well. You can click. I had the privilege to meet the 2 authors and talk and look at the book briefly. It's phenomenal. I think every one of us as an endoscopist needs to look at this. So again, don't put this aside. It's your career and your future. And the better we can do on prevention, I think the better you'll feel about your career. Second is a study about the drug vonoprazan. As you all realize, it's a potassium competitive acid blocker, PCAB. And the question is, can we use this drug on demand? And rather than have to take it, and maintenance therapy is really a daily dosing. So previous results have suggested that it may have a more rapid effect when it's taken on demand. So this was an evaluation of a 4-week run-in period in which patients who receive vonoprazan here, 20 milligrams daily, were then followed by a 6-week period after they stopped the daily to an on-demand therapy, and reporting it was really important, done on a patient report of heartburn. To get into the study, they had to be 80% compliant during the run-in period and report no heartburn during the last 7 days of their treatment. If they then were randomized, they went to a 10, 20, or 40 milligram versus placebo of vonoprazan. And it's important to do the perspective of heartburn because in the screening period, pre-treatment with the 4 weeks, 16% had heartburn-free days. And during the run-in treatment, that is when they were on therapy, 20 milligrams daily, 83% had heartburn-free days. When this was stopped and they went to the on-demand, they still had a very high number. 72% had heartburn-free days, and this was evident, particularly in response. 90% in the treatment group had their symptoms improved within 2 hours, and the data was as evident as within 1 hour. So again, we know that PPIs don't work like this, bit of a challenge for us, and it is something that, again, suggests there may be a real strong role for on-demand therapy in the patients that have reflux, which is what they did by the lead-in period of 4 weeks, show that they were acid responsive. Next was a trial looking at rifaximin monotherapy for prevention of relapse of overt hepatic encephalopathy. Recognized that the treatment use of rifaximin has been built on to the baseline primary use of lactulose, and this is the way the pivotal studies were done. Recognize, too, that lactulose is a difficult drug to titrate, and we typically will look to have patients report if they have Bristol stool scores of 6 or greater that they'd let us know. This results in an inordinate number of calls back to the clinic, your office, and it's a difficult one to vary, and diarrhea is a real problem in these patients. This is a study then that looked at the evaluation. It comes from 2 randomized trials. Dr. Jas Bajaj at the Virginia Commonwealth University presented this, phase 3 double-blind trial and a phase 4 open-label trial. These were involving child's A and B cirrhotics, and they all had con scores as it relates to gradation and as it relates to their encephalopathy scores less than or equal to 1. These are things that just then were randomized, not randomized, but evaluated with rifaximin 550 BID and no lactulose versus lactulose. It was titrated to a target of 2 to 3 soft stools a day plus placebo. So the primary endpoint here was time to breakthrough overt hepatic encephalopathies, and that was, again, the con score 2 or greater. And that was the original endpoint in both trials. There were 125 in the rifaximin group. There were 145 in the lactulose group. And it's important here, the majority of patients that were entered here, the mean age was 57. The median MELD score was 12. And again, these were A's and B's. And as it relates to the significance, it was striking because in the rifaximin group, the overt hepatic encephalopathy risk reduction was dramatic. It was a factor of 60%. The number needed to treat was 4, which is extremely powerful. And as it relates to mortality reduction, the number needed to treat with rifaximin alone was 19. So bottom line here is it's difficult to use lactulose, and certainly we frequently have to stop it, but we can be reassured here on rifaximin is a dramatic effect in and of itself, by itself. Again, first-line therapy is lactulose to begin with that, but again, we have really strong data here as it relates to rifaximin alone. The next study that I wanted to highlight, the fourth in the series, is now a use of a growing data around a long-acting glucagon-like peptide, and this is apraglutide. And this is data that was presented at DDW back in earlier this year, as far as the efficacy and risk reduction for needing parenteral support day and also maintenance of weight and fluid requirements. The question was, were variations across the demographics of the patients that were receiving this? And so this was an evaluation of the phase 3 double-blind trial, evaluating the efficacy and safety now to look at the demographic responses. So in particular, the endpoints being the same, the authors looked at the demographics as it relates to the region, the body weight, the ethnicity, the short bowel syndrome disease characteristics, whether or not there was a difference in the length or the remnant intestine, ostomy or length of intestine remnant, and the time from short bowel syndrome diagnosis. And across all these endpoints of demographics, there was absolutely no difference. This drug, it seems to be inordinately promising. Recognize this is a once weekly as opposed to liraglutide, which is problematic because it has to be given daily. From what I understand, this drug has been offered a fast-track status by the FDA. They will be, from what I understand, will be evaluating this beginning sometime in the first quarter upon submission. And what that process, to my knowledge, it means that drug could potentially be available as early as 2026. Again, a big deal for patients with short bowel syndrome with once weekly as opposed to the daily inhibiting problems of compliance and much less response. And the final study I wanted to look at was with you is the checkpoint inhibitor response. We see this increasingly in our clinics because checkpoint inhibitors are more widespread in the use. Wonderful drugs, but there is an association of up to 30% or so of immune checkpoint inhibitor colitis. Steroid therapy is the primary treatment. Again, the oncologic approach is try and keep the course, and we'll manage the GI side while we treat the colitis, and they can maintain their primary treatment for the cancer. This is, again, now looking at infliximab versus vedolizumab. So steroids are the first-line therapy. What happens if that's not working? Biologic therapy here using one of these two drugs. And there are grades of checkpoint inhibitor colitis, and this basically goes from stage 1, which is basically increased stool frequency of less than 4 a day, the absence of symptoms, so asymptomatic, and then it starts to move up. Grade 2 is frequency of 4 to 6 times a day with starting to have blood in the stool or mucus, abdominal pain. And here the question is, which is better? And so these are, again, database extractions looking at the two and sustained clinical response without a colitis episode. So here they were trying to get down to that stage 1 frequency of less than 4 a day, no overt bleeding, no symptoms. And again, the data here from infliximab and vedolizumab was quite good. 91% responded to infliximab, 86% with vedolizumab. Here, the point that I want to drive home, the teaching message potentially, the proportions of patients that after you initiate the biologic initiation of these biologic steroids were more rapidly discontinued in vedolizumab. The median days was 25 as it relates to infliximab, which took 56 days. So vedolizumab may have an added benefit here as it relates to getting treatment patients off steroids more quickly. So again, that's the take-home message. Vedolizumab may be better. We certainly are comfortable with both, but it's something, and getting them off steroids would be inordinately better. There was no difference in infection risk. Two teaching messages. One, don't forget to do a biopsy. And the biopsy is because there are patients that may have CMV colitis, and we don't want to miss that. Also, they may have macroscopically normal sigmoid, rectosigmoid, and again, that can be evident. So biopsy looking for microscopic changes. 98% of patients with checkpoint colitis inhibitors, checkpoint-related colitis, involves the left colon, so you can get by with just the Flexig. And one more teaching message, don't forget to check for celiac disease. Checkpoint inhibitor may have as a side effect, development of celiac disease, so I always order a celiac profile as well. So wrapping up 5 of the top 10 abstracts. I'll meet with you again shortly and give you the next 6 to 10. I think all these have some real clinical opportunities to make our lives more directive in improving our patients' health. I'm Dr. David Johnson. I'll look forward to finishing up with you in the rest of the ACG Highlights 2024. Thanks again for listening.